Okay, I'd like to introduce our next panel. If we can get the, gotcha. We're gonna, for the next discussion, we're gonna welcome members of the second panel, each representing the national stakeholder organizations. So we've got Chuck Ingoglia, President and Chief Executive Officer of the National Council for Mental Wellbeing, Rob Morrison, the Executive Director of the National Association of State and Alcohol Drug Agency Directors, Deb Witchey, the Chief Executive Officer of the Association for Behavioral Health and Wellness, and Dr. Rhee, Chief Executive Officer of the National Association of Community Health Centers. Again, I want to thank each of them for their appearance joining us today. They represent the key behavioral health leaders in the state and community levels across the country. Each of them has been working for many years to strengthen the behavioral health care delivery system, to break down the silos and fragmentation in care. And often they've been doing this through a patchwork of funding from federal grants, Medicare and Medicaid, private payers, state and local funds, donated funds, and more recently, opioid settlement dollars. Yet we still always seem to be struggling to maintain and sustain the system. I'm going to open up the questions to y'all, but I'm going to start with Chuck, and we continue to go around. Chuck, from your perspective, what do you think the biggest opportunities are immediately in front of us and then on the horizon to finally realize a comprehensive system of care that provides timely access to quality treatment and support of people with behavioral health conditions?
Well, thank you for the opportunity. So I think CMS and SAMHSA have been leading an incredible effort over the last 2 years through the implementation of certified community behavioral health clinics to try to bring national standards, national data, national expectations. I really resonate with something that was said earlier today, that it shouldn't matter in this country where you live. You should have access to evidence-based care, and that, I think, is a huge opportunity. And I think we have opportunities to continue to improve as a country to make sure that mental health and substance use care is integrated. And I think the emerging research around a transdiagnostic approach, I think, also is very important, not being fixated on a particular diagnosis, but really focusing on what are presenting problems and how do we help people return to their highest level of functioning as quickly as possible, I think, are really great opportunities. And then lastly, I would say we have something to learn from the rest of the world in terms of task sharing. How do we expand the universe of people who can do evidence-based psychosocial interventions beyond clinicians to take some of the pressure off of the shortage of clinical personnel that we have?
Great, thanks, Chuck. And Rob.
Thank you. Thanks for the opportunity as well. Really appreciate your leadership, and congrats on the nomination. I work to represent state alcohol and drug agencies around the country, and I think it's important that we're in convenings like this together with all the different sectors, and I can't continue to talk about that without recognizing Patrick Kennedy, who's been promoting this work across so many sectors for so many years, and I appreciate your leadership. And I also think there's an opportunity that was referenced earlier, and that's workforce, and that's something we've been talking about, all of us on this panel. And I think if folks see early on the work that you're leading here to professionalize, to continue to press on quality and data collection and accountability, quite honestly, I think it'll foster an environment where it'll incentivize people to go into the field as it's seen as a professional field like any other, as it is. Second, I also think there's an opportunity, given Secretary Kennedy's references consistently around wellness, that we talk about prevention in this sphere. In our world, prevention is critical. You can't do prevention without relying on sectors across the entire community. And we know we have to do a better job talking about the people who engage in the work of prevention. that's really important to us, that people know there's something called a certified prevention specialist, that their craft is based on expertise. And I want to recognize SAMHSA's work to promote prevention fellowship program to provide that to your. Also, finally, I want to recognize the work here at CMS to continue to have all sectors at meetings like this. I want to recognize the Association of State Medicaid Directors, Kate McAvoy is here, and the work we've been doing across a lot of different areas, but making substance use disorders a priority. So thank you.
Great. Thank you, Rob. Brian, Dr. Hepburn.
Thank you. It's a nice opportunity to be here and work with you and learn from our peers, and gives us hope. So thank you. I work with the National Association of State Mental Health Program Directors. That means that we work with leaders in all of the states and territories, and we try to help improve mental health access and the quality of services in all of those areas. So about 10 years ago, this will only take a few minutes.
We got the guy with the card up front, though, Brian.
Yeah, I can't see that far. So about 10 years ago, we decided we really need to focus on beyond beds. Services were pretty good at emergency room level and inpatient, but most people didn't need that level of service. So we started emphasizing trying to build in the services in the community to keep people out of higher level services. As a result, we've developed papers. We have about 70 papers on beyond beds. And they were led by Deb Peinels, who is one of the premier psychiatrists in the country and a really good writer. What it did is it helped all the states and territories move towards more emphasis on community treatment. Then came along crisis services, the emphasis on crisis services. Then came 988. So the Beyond Beds work that we did really played well in terms of states and territories being ready for crisis services and 988. So when you ask me what will make a difference going forward, it's continuing the emphasis on 988, crisis services, CCBHCs. We have a really good model out there. The problem is we're not able to take it to scale yet. With time, we'll be able to take it to scale. With full penetration across all the states and territories, we will have a really good system. And that's what I think will make a difference.
Awesome. Great. Thank you, Dr. Hepburn. And
Thanks. I'm really tempted to build on that, but it's not directly maybe later. Not directly related to the work we're doing at Association for Behavioral Health and Wellness. So you have just heard from the health plan members of ABHW on the first panel, and much of what they talked about is really where our focus is. So it's about the idea that we want people to have access. We want there to be no wrong door. But more importantly, we want to make sure people are getting better. Are they getting functionally better? Are they feeling better? And that really means building on this idea of quality and evidence-based care. And that's what we're all here for today. But how do we build the system that supports that? So we're not seeing little pockets of it, but we're really seeing it built throughout the system. And that's what really thrills me about looking around this room today and the people that you've gathered here, is these are all the people who are part of this system. And as I came into this role about 18 months ago, I've sat down with a lot of people in this room and heard from everyone. And what I think is really promising is that everyone has the same destination in mind for the patient, and that's the most important part. The health plans, as you've heard, and as Dr. Westlake pointed out, play a bigger role than just paying the claims, and they really can help to guide that process and work with all of the organizations in this room.
great. Thank you, Deb. Dr. Rhee?
Thank you so much. It's a real pleasure to be with all of you, and I do reflect on a quote that I often like to reference, Helen Keller's, alone we can do so little, together we can do so much. And so as I reflect on many of the faces here and the opportunities for these three panels to share, what we can do together. It's exciting. So there are three things I was just going to highlight. As a primary care doc, as an internist and pediatrician who represents the largest primary care system in the country, community health centers, I want to express definitively that mental health is health. And the importance of our opportunity to work together and think about this system and how we assure mental health is health and how it's valued. And leaders like Patrick Kennedy and so many of the folks in this room are dedicated to that core purpose. I also want to highlight, as a primary care physician who worked here at the corner of 14th and Irving when I started my career nearly 20 years ago, that I recognized that a large percentage of the conditions I was treating, of course I had diabetes, hypertension, but depression, anxiety disorder, broad range of conditions, that it was the responsibility of myself and my team to assure we prevented, screened, detected, and treated. So 70% approximately of behavioral health issues, mental health issues are treated in primary care. And the importance of advancing science and evidence in those settings is really essential. And I'm grateful to be at this table and be in this room to highlight the importance of that. The last point I want to make is the importance of two T's, I think, when we think about this opportunity. It's trust and teams. And so as I reflect on community health centers, we've grown since 1965 to now be the largest primary care system in the country that serves 52 million people, 1 in 7, including 1 in 3 in rural America. We've built trust over those 60 years in over 17,000 locations, including 1 in 4 of those locations are school-based sites, like sites that I was at, like elementary, middle, and high schools. And so that opportunity to think about mental health early and think about prevention, screening, detection, and treatment, I think is really important to do it in a whole person way, family-centered way, community-based way. So that trust is going to be so important as we look at the challenges in mental health. So I want to emphasize that. And then the team. And I loved, coming right out of residency as a National Health Service Corps scholar, the challenges of serving all these issues in a 15-minute primary care visit were significant. But having the team behind me or with me, ultimately the social worker, the psychiatrist, the psychologist, to have that team, the substance abuse counselor, the pharmacist, the dentist. We have many dentists who do mental health screenings at our community health centers. It is so important that whole team, the community health worker, works together. And so when I think about the opportunity here, it's that important area of trust and teams and how we integrate primary care and mental health and make sure mental health is health.
Great, thank you. I don't want to get too negative here, but what do you think are some of the key issues that hold the communities back and the states back from giving the care that we should be giving? I'll start with Chuck.
Well, I am so excited by your desire to look at regulatory burden and simplify. I think that is probably I see a lot of people's eyes lighting up in the room around that.
All the doctors' eyes are lighting up for sure.
Well, and not just doctors, right? If you think about, Brian mentioned 988, and the ability of everyone in this country to have a 3-digit number to connect with someone in a time of crisis has been incredible. And almost 90% of people who call that number feel like their issues have been resolved because they're able to talk to someone right away. In this country, if you present in the public mental health system, you are promised 2 to 4 hours of assessment and questionnaires, and then you come back in 2 weeks or 3 weeks to maybe see somebody, and we wonder why the modal number of visits in this country is 1. We have got to take that on.
Great, thanks, Thad.
Recently, you released the survey on drug use and health, and I appreciate all the work that went into developing the data around it. And a couple of things jumped out at me that we're still struggling with, and that was citing reasons for not receiving treatment. We're still at an astounding 82% think that they should be able to handle it on their own, that they should iron it out. And that Another significant portion said they didn't have time for treatment. And I don't think we're talking about folks who want to spend more time at the gym or at the beach, right? I think we're talking about the basic needs that they have regarding childcare, their job, where they're living, all the data that you've been promoting as core data sets, a place to live, a job, and connections. Those are core challenges that I hope this convening will help jumpstart and continue to increase access, as Chuck referenced. So thank you.
Great, thanks. Thanks, Rob. Dr. Hepburn.
Yeah, thank you. So I'll stay with 988 and crisis services and talk about one of the barriers there is the lack of participation of the private payers. Financial sustainability is a big issue, and the lack of the participation is a problem. So we all need to do a better job of getting the private sector in terms of the private insurers involved in covering crisis services. That's one. Two is that we need to do a better job of getting law enforcement and the judges involved with the crisis program, because what happens right now is that if law enforcement gets involved, they pick somebody up, the fastest drop-off for an individual, and I'm talking about misdemeanors, the fastest drop-off is arrest and take to jail. So you have all these individuals with mental health problems, substance use problems, don't need to be in jail, but are taken there because the system answer to dealing with them quickly is jail. We need to change that. Now, in some jurisdictions, we are changing that. We've gotten law enforcement involved, and they're dropping people off at crisis programs rather than arresting and taking to jail. Now, why doesn't that happen all the time? Well, one of the problems that you get into is it's a matter of, in some cases it's statute, some cases it's culture, where individuals are picked up and they're not taken to a crisis program because they have to go to the emergency room. Well, they don't make it to the emergency room because the fastest drop-off for that policeman is to take the individual, arrest them, and take them to jail. We need to do a better job of making it clear that you don't have to go to the emergency room first. You don't have to have medical clearance. You can go to the crisis stabilization program. Whatever barriers there are in the state that's contributing to that, we need to change it. A third point I would make is the Institution for Mental Disease. This category was developed in, 1965? And it was to keep the federal government from having to pay for long-term care. At that time, somebody could be in a state hospital for a year. Well, they did not want to be the federal government to pay for that. Well, now we have crisis stabilization programs, average length of stay, 3 to 5 days, that have over 16 individuals that are considered IMDs. What does that mean? Medicaid can't pay for individuals in an IMD unless they are under age 22, over age 65. So we need to do a better job if we're really focusing on the best practice model is 988 and crisis services. We have to remove those barriers in order to take it to fully across the country, full penetration, full scale.
And you bring up a great point, I think, with the justice system, and it kind of reminds me of the things that I'm seeing here, which I think are unique to HHS and to this administration with Secretary Kennedy and President Trump, is wanting to break down the silos. So we're looking to work with Department of Justice on how do we connect people, drug courts, what can we do? And again, this is not just federal stuff. The real work gets done at the state level, at the county level, and that's where y'all's work is so critical in this. And so, we're working with HUD, breaking down the silo to make sure that people get access to treatment and not just housed and by themselves. And so I think there's this unique window of opportunity. I think we all can see that we have this time that we can make some structural changes, and I hope we can take advantage of it.
Yeah. Thank you.
Yeah. Deb?
And I would concur. I think, and we've heard this throughout the morning, that a big piece of this is the fragmented way that care is delivered. And that certainly is true in physical health, but becoming less so, but certainly in the behavioral health field. And that is because some of those services are delivered by the private sector through the health plans with providing crisis services and providing prevention and providing other services through the medical model. And then we also have the piece that is being provided more through a public health model, and all of that is not always being linked together in an efficient way. We also don't really have the infrastructure in place in a way that really works well. So we've heard about I think Dr. Parsons raised the issue of interoperability and being able to build that system so that records can flow well and information can flow well. And behavioral health is not a piece of that in a systemic way yet. So that's definitely something that we need to take a look at. I would say the last thing I wanted to mention was just around this issue about workforce, and we've touched on it throughout the morning. And this really is about more than payment. There was a recent article in Health Affairs that looked at some of the workforce issues, and we have shortages in some areas, in some fields. We have geographic distribution issues, which we've talked about. There are some pipeline and training kinds of issues that make it hard to get into certain fields. And a lot of other issues around licensing and administrative burden and those kinds of things. So I think really taking a look at workforce and going back to the T and the teams is something that's critically important if we're really going to have a system to deliver behavioral health services in this country.
Great, thank you, Deb.
So I've had the opportunity in my first 3 years as the CEO of NAC, traveling to 49 states and territories across this country and listening firsthand from frontline clinicians and leaders in these health centers about the challenges that they face. And often those frontline clinicians include primary care, but also a lot of behavioral health folks who are key members of the team. And when I ask them, like a primary care clinician would, like, what do you need, or what is your chief complaint? It's funding and workforce. Those are the top two. And obviously they overlap with each other. So as we look at, and that's what's so great about, bringing the public, the private sector, payers, providers, all of us together to address that challenge, which I think is fundamentally about funding and workforce. Now, what's the solution to consider this? I'm going to go to the framework of primary care and kind of what I learned. I learned diabetes, I learned hypertension, I learned all these conditions, I learned mental health. That needs to be integrated, in behavioral health and the mental health, that needs to be integrated into the delivery of primary care. But we have a primary care workforce crisis. If you look at triple-double, there is a simple framework we've highlighted about the primary care crisis, and we need to double primary care spend from 5 cents to 10 cents on the dollar. We need to double the number of people served, starting with health centers, from 10% to 20%. And we need to double the workforce because we have a primary care workforce challenge. 100 million people in our country do not have access to primary care. So we need only 20% of people who graduate. I didn't have a strong peer incentive to become a primary care doc in underserved communities. I'm grateful, my parents supported me and I got the National Health Service score, but I'll tell you, those numbers are going down. So if you need to prevent, detect, screen, and treat mental health, you need a primary care workforce there. So that's known as the triple-double. You could Google it on Primary Care for America. The goal is 10, 20, 40. I'll highlight the goal, which I love the Kennedy Foreman, Patrick Kennedy is here, and Rebecca's here. The importance of thinking about measures and treatment. We talk about data, but 90, 90, 90. The importance of us really holding ourselves accountable to improving screening, just like I would worry about breast cancer screening or colorectal cancer screening or cervical cancer screening. Those are frequently highlighted. We need to screen for mental health and substance abuse issues, so 90% is the target. When you screen someone positive, they need to get evidence-based treatments, that's 90%. And then when they're in treatment and you're targeting recovery, that needs to be 90% as well. So you could Google the Kennedy Forum 90, 90, 90. I think it's a great, simple model for us to think about policy and practice and how we could advance and address these issues at a state level and a national level.
Great, thank you, Rhee. That's a perfect segue to the next topic. So I think one of the things that I would like to address is not just counting success by getting money to people, but actually having outcomes of getting people into recovery. And so how can we measure, this is the question, how can we measure our successes? How do we hold each other accountable for that? So what can we do, both short and long term, to do that?
So I mentioned earlier the CCBHC model and the opportunity that it presents for us to have national data. There's a lot of things I covet from the primary care world. One of them is the uniform data system, because I'm like a nerd. But we know by zip code who's getting screened, who's getting treated for what. We don't have any comparable data on the public mental health system. We need that. And forgive me, my two colleagues next to me, we have to stop this states wanting to measure everything a little bit differently. This also goes to plans. You all want basically the same information, but slightly differently. We need to agree on just a couple of common things and commit to doing it the same way.
Great.
We love all states, and every one of them. Working on data and core data sets is something we're interested in as well. And I think the exercise we're doing here is that balance between national standards and how states oversee their system. And that will be a journey we'll be on for quite some time. For us, I think leveraging the recovery community, you mentioned recovery as an example, and I see Patty from Faces and Voices of Recovery here. They have done a nice job to galvanize and to help organize people in recovery, and then go further to say, let's start measuring. Let's press for surveys, federal government, for example, to add in measures on recovery. We should. And I want to recognize the voices of people in recovery where that wasn't necessarily there a lot. I'm a family member. That, though, wasn't known to me until deep into the addiction. And only then I got to understand the real world of recovery and the needs behind people in recovery. And so sharing that is not going to be a one-meeting static exercise, but rather embedding the questions we want into every opportunity possible. So
Great,
thank you.
Great, thank you. And we only have 3 minutes left, so we have a lightning round, a minute apiece for the rest of the questions.
Okay. Thank you. I would just say that one of the things we have to be careful of is states fill out all kinds of data information. And so what we want to do is make sure that it's data that's important and is going to help with evaluating the outcomes. So I think it's basic data. How many people are getting services? How many people are benefiting, are accessing 988? We saw recently that since 988 started 4 years ago, youth suicide has gone down. Now, is there a way to say there's a direct correlation? Well, previously it was going up, and now we have young people accessing 988. It's one thing that may be very helpful. Looking at how many people are going to jail, how many people are getting stuck in the crazy competency system that we have. What that means is that an individual goes to jail and then they're referred by the judge to evaluate competency. This is often for a very minor charge, trespassing, right? So you've got this waste of money going to evaluating somebody's competency instead of getting that individual help with their mental illness. And by the way, you get stuck in that competency system, it takes months, many months to get out of that, and by that time you've lost your place that you were living in and you've lost your job. Competency system we have right now is ridiculous.
All right, well, I only have a couple seconds. I'm going to say I agree with Chuck.
Thank you, Debbie.
And so do our members. We feel that there are way too many measures, and we really want to go back to focusing on what I said at the beginning, which is, are we helping a person get better? Are we helping a person live the life they want to live? And so that's what, under the leadership of Dr. Caroline Carney, we have a group that's working now on that issue from a plan perspective to really try to focus in on what measures really make a difference, and those are the ones we're going to be focusing on.
I'll just highlight, I would challenge everyone to consider partnering with their local community health center in this endeavor. We like to prioritize the fact that we think we're the employer, provider, and partner of choice. And so you could go find a health center. It's on HRSA's website. And this is where the partnership with HRSA and SAMHSA, these are so important, these partnerships, and all of us as associations. The last thing I'll highlight is stories and statistics. As you think about how policy changes in Washington and in state capitals, the importance of telling your stories, human stories, with patients, with providers, with parts of the system, highlighting the successes as well as the failures and the opportunities for improvement is going to be important. And those statistics are important. I do agree. You measure what you treasure and you treasure what you measure. The opportunity for us to simplify behavioral health measures, and the federally qualified health centers have the UDS. It's a very powerful way for us to track quality, where blood pressure control, diabetes control, there are a few behavioral health measures there, but I think we need to simplify the measurements so payers and providers are aligned and the payment systems align with that.
Great, thank you. I think that was a fantastic discussion. For decades, y'all's leadership has really, and expertise has helped shape how we support communities around the country, state to state, community to community. We've made great strides, but we have a lot of work to do ahead of us, and I think we're going to try to get going on that right away. Got some exciting stuff that's going to be happening, pretty shortly. So again, I just want to thank y'all for being here and appreciate your.